Great pleasure to introduce our next speaker, Dr. Carol Burke, and she too is probably someone who does not need much of an introduction. She is a leader of immediate past president of our American College of Gastroenterology. She joins us from Cleveland, where she is the vice chair of the Department of Gastroenterology and Hepatology, and really her clinical and research practice and focus on education is really well known. Her clinical area and research area of expertise is in colonic polyposis and prevention, and she is extremely accomplished. She's a fellow of every one of our professional societies, I think. But what she's going to talk to us today, and this is a different type of talk that we've had, but I think it's one that's very relevant and many people have heard and probably felt, and she's going to share data about how many percent of us likely feel some element of burnout, and this is really a very epidemic type problem that has swept through all of our physician groups are grappling with this, and I think she's really become a national expert and thought leader on this topic. So without any more delay, I'd like to introduce Carol, and thank you for joining us today. Thanks so much.
Yeah, thanks for having me. Yeah, I noticed everyone's from Northern California, but we have a very famous Clevelander who's going to be joining kind of Los Angeles soon, so good luck, Lakers. Watch out, Steph. Yeah, great. And this is forward.
This is forward, and you can also use this.
Okay, great. One of the past presidents of the American College of Gastroenterology, Ron Vender, got interested in wellness and professionalism, and Ken DeVault, who was coming up in the executive board of the ACG, and I got interested in this space, and I think maybe because I felt burned out at times in my practice, and as I look around the room, there's a whole spectrum of ages of practitioners here, from young to very mature practitioners, but I think this is really important for the health of our profession and the health of our practices, so I hope that you get some tips out of this that you'll enjoy. I was enjoying George's presentation because he used a lot of cartoons, and my husband's a psychiatrist, and I just laugh at this. According to the latest scientific research, the human body is 60% water and 40% stress, and it may be higher. And it's no surprise to all of you sitting around the room what the major stressors to physicians are in this country, which includes patient and employee satisfaction, the ability to balance work and life, production pressure, government regulation, reimbursement and contracts, disruptive colleagues, the metrics that we're under, the electronic medical record, and I'll show you some data from a survey that we did, long hours and sleep deprivation, the loss of autonomy in our practices, maintenance of certification, if that resonates with any of you out there, spending time on tasks that are inconsistent with your own priorities and litigation. But amongst this, you feel like, where can you go for help? And it sometimes feels like it's really not manageable. And I think the burnout crisis really happened with the healthcare reform, where the Institute for Healthcare Improvement said, there's a tripartite goal as we move forward. It's to improve the health of populations, enhance patient satisfaction, their experience and quality, and decrease the cost of care. And who's integral to this is the physician that's in the middle of it, but they never thought about the physician who's really suffering the most in this. And so when we think about burnout, we think about our practices, you need to think about the biologic implications of stress. And acute stress activates many axes within us, and excess and sustained stress hormones, especially cortisol, leads to disease, hypertension, osteoporosis, immunosuppression, insulin resistance, on, cardiovascular disease, depression, anxiety, burnout, and death. And I've actually witnessed administrators in my department stroke out. I had a former chairman that the head of our fellowship program and I would sit in our offices at night and said, we need to go to his office. We think he's going to die on the job. So this is real. And it's not just in the United States. This is really stunning data that really focuses on Asia, but in the United States, 45% of physicians work more than 60 hours per week versus 22% of Japanese and less than 10% of US workers. So we really work hard. And it's interesting that in Japan, there's no word for work-life balance. They have a word, though, for death by overwork. It's called karoshi, and it's considered the inevitable result of Japan's work culture that's hardly discussed. And governmental claims have risen to a record high of over 2,000 in 2016, and that's an unfortunate family whose son actually jumped off an apartment building because he was working to death. And when we move to physicians, it is no surprise that physicians are impacted by this overwork, and this was from the New York Times a few years ago, but it's sustained. 2 medical residents in their second month of residency training in different programs jumped to their deaths in separate incidents in New York City. Physicians are more than 2 times likely to kill themselves as non-physicians. Female physicians are a particularly high-risk group, more so than male physicians, and over 400 doctors commit suicide every year. So this is a phenomenon, it's an epidemic when we need to take it seriously. So what are we talked about the biologic implications of stress, but what are the workplace implications of stress? Certainly burnout is one of them, disruptive physician behavior, decreased productivity, poor quality and safety for our patients, and then disengagement in the workforce. And it's a funny cartoon here, and I had a partner that said this to one of our trainees, and this person is actually speaking to their boss. And how can you be suffering from burnout? You've never really caught fire in this organization anyway. So American worker engagement. You're all in groups, I presume here. You're all managing somebody. If it's not a whole staff of people, at least you're managing your research nurse or your NP or PA. 32% of American workers feel engaged in their job, but if you can engage your employees, they will be more satisfied and productive when their core needs are met. And this extends to physicians as well. So you need to have the opportunity to renew and recharge at work. You have to feel valued and appreciated for your contributions. Allow people to focus on the tasks that are more important to them, and let them define when and how the work will be done. And then certainly people, so spiritual is a feeling connected to a higher purpose at work, and it doesn't have to be a spiritual connection, but if you can actually create a mission and vision for your center or your working group, I think that is the connection that people need to buy into in order to improve. So what really is burnout? And it's a work-related syndrome characterized by a low sense of personal accomplishment, emotional exhaustion, I just can't see one more patient, or a depersonalization, cynicism, and a lack of compassion for others. And there are 3 real domains to this burnout phenomena. Of course, I think at the top is the organizational culture in which we're working within. Certainly part of it is on us and our grit and persistence and resilience, but also its practice efficiency. So we'll actually target some of those. Tate Shanafelt, who is now here in California, was the burnout expert, and he left the Mayo Clinic in Rochester, but he and Noseworthy actually have written a number of articles on this, and it really is a healthcare epidemic. And you can see on the left side of the figure there that it has impacts on your personal life, broken relationships, alcohol and substance abuse, depression and suicide, as we talked about. But again, on the healthcare side of things, the decreased quality of care and increase in medical errors. And there was a recent study that they just published in Mayo Clinic Proceedings, again, on increased medical errors. Decreased patient satisfaction, which is really important in terms of getting paid for what we do, as well as patients in your practice and increasing the patients within your practice. Decreased productivity and professional effort, and then physician turnover. And if you have lost partners, you know it costs 2 to 3 times of their salary in order to replace a partner. What are the organizational drivers of burnout? Excessive workload, inefficient work processes, clerical burdens that have shifted to us rather than just taking care of our patients, the lack of input or control on our practice issues, and then the misalignment of the values between the providers and the leadership in the practice. We did a national survey of burnout in gastroenterologists. There had not been one, although there had been done in primary care and many other subspecialties, and a lot of Tate Shanfeld's work had been done in surgeons. But what we did was a survey of ACG members to determine the prevalence and the factors associated with burnout. And it was a 60-item survey mailed to members. Maybe some of you had taken the survey. And basically what we defined as burnout was high scores on emotional exhaustion or depersonalization on the Maslach Burnout Inventory, which is a tool that's available that you can use in your practice if interested. We use the formalized scale that's 22 items. And you can see the scoring system there that's available for you online if you're interested. And we sent the survey to 11,000 ACG members. We got a 9% response rate. 754 patients completed all the 22 MBI questions. Many more than that completed many of the other questions that were in the 60-item survey. But what you can see is that about 20% of people have burnout if you looked at the sense of personal accomplishment, 45% for emotional exhaustion, 21% for depersonalization. So really 50% of clinical gastroenterologists that responded to the survey actually had high levels of burnout. And I just want to go over some of the interesting things. We might think that there's certain practice-related things that would lead to burnout, and I was surprised. But it's no surprise women are more likely to report burnout than men. Younger individuals are more likely to report burnout than older individuals. And things that didn't seem to have an impact, some of which are surprising to me, is whether you're part-time or full-time, if you're in private, academics, a VA, or other healthcare setting, if you're in a suburban or a rural or urban practice. Compensation type didn't seem to make a difference, although you'd think if you're based on productivity that you might have more burnout in your practice because people are pushing themselves higher. But in our survey, it didn't make a difference. And if you look at the bottom there, you can see that people that thought the electronic medical record was not user-friendly were much more likely to report burnout than those that either did not use it or thought that it was okay. When we go down to the domestic characteristics, individuals that are spending more time doing domestic chores at home and caring for children have higher rates of burnout, and that may be the gender disparity that we see. Individuals that are taking patient-related tasks at home and then doing non-patient work-related tasks at home, so more than just charting at home, you're doing other things related to work at home, but it's the patient-related tasks at home that seems to lead the burnout. The hours per week that your employed spouse spends at work or at home and related activities seem to also impact burnout, so it's that work-life balance that both you and your spouse have. And it didn't seem to matter if your spouse did more of the domestic chores or caring for children, but it was the physician that was doing those that seemed to impact burnout. These are some of the sad statistics about marriages with physicians. Satisfaction with your spouse or partner. So individuals that had higher rates of burnout were more likely to say that they had a neutral relationship with their partner or dissatisfied with their relationship. And then there was some impact on age of child and burnout rates. You can see the age of the youngest child and the age of the oldest child had some impact on burnout. I was interested in wellness, and we looked at physical activity according to the CDC.gov recommendations, and you can see that people that were couch potatoes or exercised according to regulations didn't really seem to have higher or lower levels of burnout. But when you look at people who are eating breakfast and lunch more than 50% of the time, those people are more likely to say they don't have burnout. And when I look at the mature audience sitting here, thoughts of early retirement, 46% of respondents actually said, I'm retiring earlier than I anticipated. You can see the breakdown. Mostly it's regulatory things. It's the regulations, it's reimbursement, it's ABIM and MOC. The electronic medical record was only 10%. Personal or family issues was only 5%. But when we looked at individuals that said they're going to retire early or leave their practice in less than 2 years, those individuals, burnout was in 64% versus 35% that said they weren't thinking that. So a lot of what's changed in the transition as healthcare is leading to this. And we did a multivariable analysis that looked at, the younger the age of individual, the more likely the burnout. The electronic medical record trended toward increasing burnout, increasing domestic chores by 3-hour increments per week. Individuals that were more satisfied with their relationship with their spouse had lower rates of burnout, so take time to spend some time with your spouse this weekend. Again, the child thing we talked a little bit about, the eating, lunch, a trend toward significance, and certainly if you're thinking about leaving practice, you're 3.5-fold more common to be burned out. So what about this disruptive behavior? Impact of disruptive behavior: poor adherence to practice guidelines, loss of patients in your practice, low staff morale and turnover, medical errors, adverse outcomes, malpractice claims. And then, communication is key if you're in the endoscopy room, if you're in the surgical suite. So consistently, doctor-patient, doctor-doctor, and staff-doctor communication is a leading disruptor of team function and risk management activities. And certainly, if you're managing the disruptive employee, then you have the converse of all those. It's been shown to improve staff satisfaction and retention. Your practice actually has a better reputation. You're creating a culture of professionals who are role models for trainees and for one another. You will show improvements in patient safety, reduce liability and risk management activity, and then greater productivity, civility, and desirable work environment. And I've been to Google both in Pittsburgh and in California, and I thought if hospitals were run like Google, people would work 80 hours a week and be happy as a clam, because you get to get the work done when you want to get the work done, and everything that you need is right there. So what about wellness in practice? We talked about the burnout aspect. So wellness is the ability to be curious and self-aware and resilient and fully present in the environment that you're working in. And it needs to support good relationships among your partners, patients, and families. And when we think about physician and wellness and how we take care of ourselves, it's fascinating. And I just want to see a show of hands. If you were sick with a headache and nausea and maybe some diarrhea, how many would still go to work? Virtually every hand is up. Okay, so this was an interesting study that was published in JAMA Pediatrics, and they had about 250 advanced practice providers and 280 physicians. And they looked at the symptoms. This is a survey that you would go to work with. Fever, chills, and body aches. 20% of physicians would go to work, 11% of the advanced practice providers. Acute significant respiratory symptoms, 60% would still go and be spewing germs all over their patients and their staff, 51% of APPs. Acute vomiting, diarrhea, that does keep us at home, right? Less than 10% of people will go because maybe you don't have access to a bathroom, or you're not wearing your Depends when you're doing endoscopy. Fevers, less so. Diarrhea is a big one. Vomiting, people are still going to, few people go to work. And if you have the kind of common cough and cold, people will still go to work. But this was fascinating. Important reasons why I go to work sick. This is all physicians. 95%, I don't want to let my patients down. 98%, I don't want to let my colleagues down. 58%, I will be ostracized if I stay home from work when I'm sick. 45%, the leadership is not supportive of a sick leave policy. 95%, you are worried that there's not enough staff to take care of the patients. 12%, very few, run out of sick leave or coverage. 55%, I am the only one that can do what I do. 58%, I'm worried about patient handoff and continuity of care. And 70%, I do it because my colleagues do. So we're setting a very poor example for each other. Let's talk about other aspects of our health and wellness. Which physicians are the most overweight? So Medscape has these surveys all the time. Gastroenterologist, 47%, the top three, general surgery, family medicine, gastroenterology. So we're some of the most obese practitioners that are out there. And when you take a look, you can see that mostly it's men compared to female gastroenterologists. And then this was an interesting aspect of how often do gastroenterologists eat out, and you can see that eating out at least weekly, about 43% of normal weight gastroenterologists, almost 60% of overweight or obese gastroenterologists, and you can see at the bottom there that almost 10% of gastroenterologists are eating out daily. What about wellness? And this is vacation, and there's strong data that shows if you don't take an uninterrupted 2-week vacation, that you cannot really reset. And so this shows which physicians are more likely to take 4 weeks of vacation or more per year, and gastroenterologists, much less than 20% are actually taking 4 weeks of vacation per year. Satisfaction with work-life balance. This is, again, from Tate's work, and it shows that mean satisfaction of physicians with the ability to work and engage with your family and your spouse, less than 50% are satisfied. And this was a study that compared almost 6,000 physicians to 3,500 individuals in the normal population. And when they said, what is your satisfaction with work-life balance, you can see by far and away that when you get to the neutral, disagree, and strongly disagree with work-life balance, it's much more in the favor of physicians rather than the general population. Can I see a show of hands who has a spouse, partner, husband, wife? Most everybody here. APGAR of medical marriages. When Tate surveyed almost 1,000 physicians, only half were extremely satisfied with their relationship with their partner. 31% were somewhat satisfied, 4% neither satisfied or dissatisfied, and then somewhat or extremely dissatisfied, 10%. Isn't that a sad state of affairs? We started medical school, we were so happy we'd do anything to get in, we met our partner, we were so happy we couldn't wait to get married, and then to have these results is really awful. And I think part of it is that we don't spend time with our spouse, and you can see that the time spent awake, not asleep on the couch next to your spouse, but this time spent awake, engaging with your spouse, these are minutes per day. Only 28% of physicians actually spend more than 2 hours awake with their spouse per day, so very little time. So let's talk a little bit about getting to some of the nuts and bolts of what we found in our survey, this eating thing. And this is a study that was an intervention on nutrition and cognition, and it was a food and beverage intervention in 20 physicians in hospitals in Canada. And what they did, the intervention was 6 small meals per day as well as access to water. And they assessed hypoglycemia and cognition by a little app called the Brain Checker software. And you can see the baseline changes in mean blood glucose on the right side of the screen. It's the dark line. And then the dotted line shows after the intervention. And what was shown that intervention improved the speed and accuracy of cognition, lower and less variable blood sugars, and then increased hydration when physicians actually take breaks throughout the day to ensure that they're eating and drinking. And maybe that was one of the reasons in our study where we found that adenoma detection rate decreased as the day went on in one of our studies. What about diet and chronic disease? So I'm speaking to you sitting in the audience now, and you can share this data with your patients. But we know that the leading cause of morbidity and mortality in Americans is really lifestyle diseases, cardiovascular disease, cancer, and diabetes. And this prospective cohort study assessed smoking, BMI, exercise, and a plant-based diet on the incident diabetes, MI, stroke, and cancer. And it's data from 23,000 individuals between the ages of 30 to 65 years old that were followed up for 8 years. And you can see the incidence of those lifestyle diseases are substantially less as time goes on in individuals actually that ascribe to one or more of those lifestyle factors. So if you didn't ascribe to any of those factors, you had a substantial increased risk of those diseases. And all 4 factors that individuals engaged in, including lifestyle and diet, had a decreased incident disease of diabetes of 93%, MI 81%, stroke of 50%, and cancer by 36%. So simple things that you can counsel both you and your family as well as your patients on. So let's get to burnout and wellness and physical activity. The CDC.gov is something that I always give to my patients, and I put in letters after I do colonoscopy about decreasing body weight and healthy guidelines. And the guidelines are not very rigorous, so you should be engaging in 150 minutes of moderate intensity aerobic activity or 75 minutes of vigorous intensive aerobic activity, or both per week. That's per week, plus strength training, because that improves your immune function, involving all major muscle groups 2 or more days per week. So very low levels is our national standard. And when Tate assessed wellness and physical activity, this was in 7,000 surgeons, you can see that barely 20%, actually under 20%, engaged or met the moderate physical activity recommendations, and very few met the vigorous activity recommendations by the CDC. So overall, only half of these surgeons met the CD recommendations for aerobic activity, and 1 in 3 for strength training. But it's been interesting when you look in their study of the factors associated with a high quality of life. When the surgeons were compliant with CDC activity guidelines, 20% increase in a high quality of life, And doctors that said they find meaning in their work, also associated with quality of life. They have a positive outlook. People that incorporated work-life balance had a higher quality of life, focusing on what is important in life, taking vacations, recreation, hobbies, and exercise. And the things that were inversely related with a high quality of life in this survey was physicians that are regularly meeting with their psychiatrist and those that are looking forward to retirement. So some of the same things we found in our survey. But what about exercise on burnout and quality of life? This is a survey of over 4,000 medical students, and they compared burnout and quality of life in the trainees that met the CDC target for activity versus those that didn't meet the target. And they took a look at both the aerobic guidelines as well as the strength. And what they showed that in the survey, the medical students, 63% actually met the aerobic activity recommendations, and their levels of burnout were substantially less than those that didn't meet it, and their quality of life scores were substantially better than those that weren't meeting the aerobic activity. And when you look at strength training again, you can see that their levels of burnout were less and their quality of life was higher. And the independent factors associated with lower burnout, again, was both the aerobic and strength training. So that would be something simple that you can incorporate if you feel like you're on the edge. This was an intervention study. So the last one was just a survey study that assessed that. But this was an intervention study of over 1,000 trainees. This was at the Mayo Clinic. And they invited them to a 12-week physical activity program. And they did a survey at baseline and 3 months to assess the physical activity, quality of life, and burnout. Only slightly over 600 of the residents completed the baseline survey. 1/3 met the CDC physical activity recommendations, and the median quality of life was 70, and on a score of 1 to 100. Burnout at baseline was seen in 1/3 of these medical residents. 23% enrolled in the physical activity program, and the baseline characteristics were similar between those that enrolled and those that didn't enroll. And what you can see is the physical activity results. At the end of the training session, the participants in the program were actually, a significant number had met the CDC recommendations for moderate physical activity, and a substantial number increased the vigorous physical activity. And when they take a look at the outcome according to the quality of life, meeting the exercise regimen and the burnout prevalence, you can see that those individuals that increased their CDC recommendations, 48% versus 23%. Quality of life was substantially enhanced, and burnout prevalence was decreased, but not substantially so. So even an intervention seemed to have an impact on burnout, although not statistically, but quality of life. This is a little survey that was done looking at physician and patient satisfaction in 11 general internal medicine practices in Boston. It was a random sample of over 2,500 patients and over 150 physicians. And what they showed is that physicians that were very or extremely satisfied with their work had higher patient satisfaction scores. That's no surprise. Younger patients, those with better overall health status, and those cared for by a physician who worked part-time were significantly more likely to report better satisfaction measures with their physician. So you might think about that in your practice if you're struggling with patient satisfaction, that there are some factors that seem to be important, and one of them that stood out for me is the physicians who work part-time. What about sleep? There is a few sleep inventories that you can use if you want to do some studies in this. And this was the PROMIS Sleep Disturbance Scale. And what they did is survey 213 clinicians and trainees, and they found that sleep disturbances were associated with less mindfulness, less self-compassion, physical and mental health, and strongly correlated with perceived stress. So if you're struggling with low or high opportunity work units, you might want to take a look at sleep inventories, and maybe this is appropriate for some of the program directors too. So when it comes to wellness promotion, certainly you can look at it by personal strategies as well as organizational interventions. And for the personal approaches, I think it's time that we need to take a self-assessment to determine whether we have signs or symptoms of burnout. We need to prioritize our work-life balance and adopt healthy behaviors, and I've shown some data that speaks to that. Engaging in recreation is an important thing that you can do on a personal level. Practice mindfulness, and there's a variety of different tools that are available for you, and find meaning in life and meaning in your practice. There's some strong data, both meta-analysis and systematic reviews, about the impact of interventions on burnout, well-being, and patient care. And what's been shown is that facilitated interventions improve short-term and sustained improvements in well-being, attitudes associated with patient-centered care, meaning and engagement in work, and reduce burnout. And those are the interventions where staff are given the opportunity to meet together, talk about cases, talk about their practice, maybe talk about inefficiencies in their practice. They also teach them skills such as mindfulness, meditation, reflection, and shared experience. And I've given you some references there if you're interested. Both individual and organizational strategies result in clinical meaningful reductions in burnout, but I think the key takeaway for many of us, because we feel like it's all on our shoulders, is that organizational interventions are more effective than individual-focused interventions. So the steps to prevent burnout and improve wellness, this might be a menu for you. To cultivate a community in your practice that recognizes this and ensures that it's important. And how do you ensure that it's important? Well, establish wellness as a quality metric. There's the Mini-Z burnout survey that Linzer has created. You can go online and take it. There's the Maslach burnout inventory that we used in our study. The Mayo Clinic has their well-being index. So I would say, instead of us getting measured on our urinary tract infections and C. diff and wrong site and ADR, patient satisfaction, let's look at some metrics that might be important to us in our practice. Identify high opportunity work units. So if you do measure burnout and wellness, you will find your work units. Maybe it's nurses in the clinic, maybe it's MAs in the clinic, maybe it's the nurse practitioners in the hospital setting. If they have higher levels of burnout and lower levels of wellness, those are the ones that you may want to target. So it's the lowest scoring work units on the metric that you're looking at. And then engage those units to identify factors and improve satisfaction and allow them to figure out what the solution is to improve their satisfaction with work. And it's interesting, at the Mayo Clinic, they actually have a scorecard for their leadership, and Noseworthy's goal was that 50% or more of the work units that were identified as high opportunity work units had to have an improvement within 12 months. So the organizational actions, and it doesn't have to be a system like Kaiser, it doesn't have to be Palo Alto or John Muir or the University of San Francisco. It could be your private practice. So you need to acknowledge and assess the problem, and then harness the power of good leadership. And at the Mayo Clinic, each 1 point increase in a leadership score of the physician's immediate supervisor was associated with a 3% decrease in burnout and a 9% increase in satisfaction. Leaders have to recognize the unique talents of every individual in the group. We're not all the same. Someone might be better in quality, someone might be better in research, someone might be better in general GI. In addition, if you have individuals that are burned out in your practice, strong data time and time again shows that physicians who spend 20% of their professional effort on meaningful work have dramatically lower burnout. And I love to see hereditary colon cancer patients. Most of my practice is that, and I'm very happy. I've been in the practice for 23 years. Each 1% reduction below that 20% line increases burnout. But it's interesting that the ceiling is at 20%, so you don't really have to give the baby away with the bathwater if you're managing a group. You need to align the values and strengthen the culture, so you need to ensure that the organization and the physicians are working toward a common goal. The leader should request candid feedback on areas for improvement, and then create a mission and vision statement. Have an enduring document that articulates your practice, your foundational principles. Promote flexibility and work-life integration. Consider allowing some employees to work less than full time. What about flex hours? Maybe you need to get your kids or your wife to a radiation therapy appointment, whatever it is. Maybe that individual could start at 10 o'clock rather than have to start at 8 o'clock, and maybe they can flex their hours and come in at night, working less than full time or the flex hours. How about virtual visits or shared medical appointments? We've instituted those at the Cleveland Clinic. They increase both professional and patient satisfaction. And then provide resources to promote resilience and self-care. The AMA has a lot of these. The ACG also has some of these available online. And then gender considerations. 10 years ago, every man that I knew was coming to me and saying, do you know any women that are interested in my GI practice? Because it is a plus to have a female in the group. Unfortunately, the reality is that female physicians have more female patients than male physicians. That's not a problem, but patient expectations differ between female and male patients, as well as the expectations of the patient on a female versus a male physician. Female patients tend to seek empathic listening and longer visits, especially with female physicians. Female physicians are not provided more time to see female patients, and this is particularly important when it comes to pounding out colonoscopies in women all day long, especially with the higher ergonomic injuries in women. It's much harder to do colonoscopies in women for a variety of reasons, and that's been well documented. The gender differences in patients and expectations of female physicians may contribute to burnout among the female MDs, and part-time work to reduce stress in their work lives might be beneficial. I think maybe a lot of part-time employees take their work home, so they work when they're not getting paid. But consider increasing the visit time for female patients and female staff. Let the staff be aware that female patients may be more time-intensive. And then consider adjusting for patient gender and compensation plans. You know, if the women are pounding out female colonoscopies and seeing more female patients, that might be something, especially with a higher gender burnout in female physicians. This was a study that was published recently on the impacts of scribe, and suffice it to say that there's many aspects about having a scribe in the practice that improves satisfaction. Basically, physicians said, this is before a scribe and after a scribe, that they're more satisfied with their role in clinic. They agreed or strongly agreed. The control over workload was slightly less, so saying that they had poor or marginal control of their workload was slightly less. Time for documentation that rated poor or marginal was substantially decreased in individuals with a scribe. Individuals, the physician said, I'm able to listen to my patients, agree or strongly agree. They thought they were providing higher quality of care with the scribe, and then the amount of time spent at home on the EMR was substantially reduced. So there's a lot of benefits to scribes. The only problem with scribe is, okay, we're giving you a scribe, we're paying for that person, now you need to double or triple the amount of patients that you're seeing. So you got to think about that. So in conclusion, physicians are substantially affected by workplace stress, and stress leads to burnout, and rates in gastroenterologists we've documented are 50%. It may be that it's a bias that those who are more burned out reported to our survey, but when you look really across all groups of physicians at 50%. And the stress that leads to burnout impacts the professional behavior of the individual, the quality of care and communication. There's decreased professional and personal success, decreased satisfaction, quality of life and wellness, and it really threatens the physician workforce. And both personal and organizational strategies are required to maximize physician wellness and decrease stress. In particular, I think it's the organizational strategies that we need to look at. And I always like to remember that stressed is dessert spelled backwards. So whenever you're in that situation, just grab for a piece of chocolate cake or a chocolate chip cookie, and that might help. Here are some resources that might be beneficial if you're looking for help in your practice. The AMA has the Steps Forward program that has PowerPoint. You can get some CME for it. The NAM, the National Academy of Medicine, also has some resources. The ACP has resources, as well as the American College of Gastroenterology. Thanks for your time, and I'm happy to answer any questions. Yes, sir.
How do you deal with organizational? Speak up or use the microphone. Yeah.
I can repeat the question too.
How do you deal with organizational problems at your institution where you're trying to provide care, but the institution is not giving you the opportunity for various reasons? I mean, I think that is a factor that leads to not necessarily burnout, but definitely frustration on the physician's part.
So the question is, when the organization doesn't seem to support your need for either help in the practice, time to see the patients, there's emerging data that actually shows kind of some of the last slides that I presented that you need to choose a leader in the practice first of all, and I don't know what type of practice you're in, but if it's your private practice, you are the leader in the group. And I think measuring burnout or wellness or patient satisfaction would be the first thing, but in terms of us, measuring the metric, wellness, burnout is the first thing. If there's no problem at your center, there's no problem at your center. If there's a problem in your center, then you've identified it. That's when you take it to the leadership and say, we're suffering. The other thing is if you have patient satisfaction data that mirrors some of the physician dissatisfaction, then you can say this is an important point. Because when we're going to MIPS and these alternative payment programs, you're getting paid for basically patient satisfaction as well as some other metrics. But I think the first thing is to measure it. So you need to recognize and measure, take it to the leadership and say we have a real problem there. And some of the most effective centers that have utilized that approach where they've taken it to leadership. So this is a standard at the Mayo Clinic. I'm creating a work group at the Cleveland Clinic. But it's bringing in some of the other providers too. So it's not just physicians, it could be your office manager, it could be the advanced practice providers, the MAs, call center, so bring the people together and then once the leadership says, yeah, this is a problem, then you need to design the intervention. So it's, measure, do, measure, and react to it. So do you have a specific thing about when your leadership doesn't take you seriously, or I'm not sure what the basis of?
Well, they say the data doesn't show that you need to change certain things, even though the problem is like especially inpatients, it's very cyclic, and there are times where things are very slow, but there are times where things get extremely busy and we can't accommodate for that sudden volume increase. But overall, when they look at the numbers, they say, well, you don't meet the criteria for us to provide for additional nurses, additional this, additional that. So it's frustrating, and I've always argued saying that, well, listen, this is adding to extra hospital days for the patients to stay, so that you can do a procedure on them. You couldn't do it today, so it has to be done tomorrow. You're losing money, but they don't seem to connect the dots.
Right. So again, my partner who is on so we got away from our own primary inpatient service because we were being killed with HCAP scores. Chronic abdominal pain. The Cleveland Clinic says, oh, we'll accept anyone. Mayo says no. University of Michigan. And so we finally got away from our own luminal GI service, which is great, but now we're all consultative care. And my single partner and a fellow had 38 patients yesterday, which is a ton. But he doesn't call out for help. But it gets to the point that things are cyclic, and I think data is the most compelling thing to result in change. So if you could actually get some data on an increased length of stay because you don't have people able to get the procedures done. So I think data is the only way to get around that. And then some of this more provocative data related to scribes. There is other data that shows that when you have a scribe in the clinic, don't expect that you're on easy street. You will need to increase your productivity, but if you're doing less of the computer physician order entry, that you're moving on to potentially the next patient while your scribe is finishing up, or your NP. So you can create systems. There's a lot of data out there that can help you with this. But I think data is the only thing that's going to drive people to change, and showing that decreased productivity, decreased patient satisfaction, increased medical errors are all a function of doing clerical related and inefficient practice aspects will help your leadership change. And then the other thing is, maybe you need to be the one that goes to leadership and says, we have a problem, let's create a mission and vision statement. And I know it's easy for me to say because it takes time, but you all have to buy in. And I tell the young people in that are looking for career opportunities, it's like a marriage. And if you aren't on the same page, if your group, all they care about is trying to do as many procedures and take as much money and don't take vacation, then your work-life balance is not a priority for them, and that's not the practice for you. So I think data is one thing. Creating a work group yourself, going to leadership and say, here's the problem, here's the data, let's make this a metric to measure, would be very compelling for most practices.
Carol.
Yes, Eric.
Thank you for that great talk. And I have a question for you. I think you addressed this a little bit. First, it was really interesting to hear the GI perspective too, because it's mostly often cast as a primary care problem, even though we know this is a physician problem. What do you think? We've heard about, you talked about things we do as individuals, and people talk about resilience and mindfulness and things you do at a local level, at an organizational level. And your role as past president of the ACG, what do you see at a national level? Because many of us feel that many of these pressures are really actually coming from organizations even well above our own, whether it's from CMS and the newest guidelines, whether it's the reduction in RVUs and pulling out moderate sedation, whether it's affordable care and the 15 clicks that now come. Is there hope, you think, at a national level to reform the job of the physician? And the physician job, we have people at all ends of the spectrum of their careers, but the job of the physician today in gastroenterology is extremely different than the job of the physician was even probably 20 years ago.
Yeah, that's an important question. There is a lot being done at the national level. So you know that Seema Verma actually went around, and she has an initiative that it's patients over paperwork now. So they've recognized that this is a serious problem, and so they're trying to get away from some of the things that we need to do, like why do I need to fill out the non-GI review of systems when the MA could do it, or my LPN or somebody else could do it. So they're recognizing this phenomena of burnout and the epidemic in physicians. The other thing in terms of the transformation in healthcare policy and reimbursement, with MIPS and bundles of care, our ACG governors, and I'm sure there's many of you sitting around the room or other individuals that are interested in going to your local legislator or going to Washington, and we've talked to them about these bundles of care and MIPS and attributing costs to the gastroenterologist, right? So they've contrived this crazy system of reimbursement based on 4 different things, and we've been successfully able to battle this attribution of cost to physicians, because there are some physicians that do IBD or do hepatology, or individuals that are doing high-risk polypectomy and patients are admitted for GI bleed, and you may be the physician caring for them in the hospital, but so is the ICU and somebody else. And the government has these great ideas, but we have workforces that are sitting with CMS and going to Washington, D.C. saying this stuff is crazy, and so they actually have delayed the cost attribution portion of MIPS to the physicians for a few years. So we are not going to move the needle unless we are proactive and you go and talk to your state legislators. You need to go to their office. You need to tell them what you're buckling under the pressure of things. And for instance, another one where pre-authorizations, you have to sit and it's 72 hours later. And so, we've moved legislation in the state of Ohio. We've moved national legislation, alterations in maintenance of certification. So I think, Eric, a part of this is we can't sit back and let CMS and the government tell us what to do. We need to be in our legislators' offices telling them what the issue is, and things are happening in terms of reimbursement, cost of care, bundled payment, MOC are some of the ones that are impacting. And then I glanced over a couple things pretty quickly. Does anybody do shared medical appointments here? So when you say, we just don't have enough people to see all the patients or to do the procedures, if you have similar disease states, let's say Lynch syndrome or GERD or IBS, now everyone's slightly different. We do it in women's health, we do it in diabetes and asthma, we do it I share it in colorectal surgery with our Lynch patients. We have it for gastroparesis. Instead of patients stopping at the front desk and sitting in the waiting room and then going to the MA and then being put into a room and then you see them, you have like patients when you call and say, hey, I want to see Carol Burke. My next available is January 29th, but she can see you for a shared medical appointment next week. So you come in and everybody goes into a conference room. There's a medical assistant that's doing the vital signs and kind of the check-in. And there's a facilitator. So let's say it's GERD. So you have, your nurse that does Bravos or manometry or something, and she's talking to Joe, and Sally's like, okay, Joe, what questions do you have for the doctor? So all the patients are in the same room, their vital signs are all done, the questions of all the patients, or they talk about, a diet, low FODMAP diet or something like that, and then you come into the room while this kind of education thing is going on, and you're doing, for GERD patients, you don't need to do a rectal exam. You're not, your heart and lungs, so, you're doing the exam and talking to each patient, and we've seen 7 to 9 patients in a session, and then you get up and say, okay, we're all here to talk about GERD today, or whatever the disease state is, and these are the questions you guys have. This is what leads to reflux. These are the treatments for reflux. This is the complications of reflux treatment, and then you've actually billed a level 4 potentially on 7 patients in an hour and a half. And in chronic disease management, it's been shown that there's improved patient satisfaction, improved disease control, and physician satisfaction. So a shared medical appointment is something to think about. The Cleveland Clinic has 200 of them, so you can think about that in your practice as an innovative way. So patients aren't going all around. They go to the conference room and they all start there. And the other thing is we do, does anybody do telehealth now? Yeah, so, I love telehealth, right? So I can be sitting in my pajamas. I don't go to work in my pajamas, but potentially you could have a shirt on, but patients love it. So, they have to swipe their charge card in. It's not paid for by insurance yet, but that is coming. And basically patients are sitting at home and they're sitting in their office for, 15 or 30 minutes talking about their follow-up care. I can't do it for new patients out of state yet, but that's another way to consider things. And the only other 2 things that I saw in the news recently is that insurance companies, or actually Donald Trump maybe, you will get a tax break, $500 per individual, $1,000 for joint filers for a gym membership, and you can actually write off your yoga class expenditures. That's a potential future. But there's many innovative ways to get to efficiency in the workplace. I think a scribe is a great one. A shared medical appointment is another way to think about it, and then trying to change the culture within your group. Bertina.
How do you do note writing for shared visits?
Yeah, so you can actually have a scribe with you, or the MA actually is inputting most of it, and it's just a brief physical exam. So the issue is you need to have a good facilitator behind you, like talking about what IBS is and what a low FODMAP diet is, or hypersensitivity, whatever you want to talk about. So you're kind of typing as you're seeing, so you have the computer that rolls around with you. And most of the intake is already done. And then you can have your nurse or just put, the disease, because it's all GERD or it's all disease state in it. Yeah, so it's done in real time. But most of that pre-work is done by the MA in the conference room. And then if you have to do you have to look at something that's sensitive, then you just take that patient out to the exam room around the corner. But most of our disease states, you don't really need to do, any sensitive assessment of the physical.
Did you have to deal with any HIPAA issues in shared visits?
Oh, yeah, so we have some visits with parents and children or friends come in, so everyone needs to sign a HIPAA and confidentiality statement that they can't share about. And the other interesting thing is the people that come to share medical appointments, it's kind of creepy. They want to come back with those people for their next shared medical appointment. But by the engagement of patients talking about disease state together, I think maybe that's some of the improvement in their satisfaction and their disease control.
I was just going to share, we have shared medical appointments in our organization. I looked at trying to start that for some liver conditions, and I attended a shared medical appointment in psychiatry, which was just fascinating. And there were an assortment of patients with all different disorders, obviously very sensitive stuff that people were talking about, very personal. And the psychiatrist and the facilitator and many of the patients said that they love that forum. They actually feel empowered by seeing the other people around them, and they did want to come back. They did say exactly that they wanted to come back with some of these same people. So I think the patients probably self-select. There are going to be some patients who I imagine never would want to share anything, but those that do seem to really choose that setting.
Yes, ma'am, question there. Could you give her the mic?
When you have these patients in a group, that they all have to sign these releases of confidentiality to have their information shared with strangers whom they've never met.
That's right.
Yes. And have you ever studied the patient lack of wellness and burnout with what's going on in the medical system nowadays? And have you ever asked patients how they feel about electronic medical records that are littered with errors? Diseases they never had are written down. Diseases that have been quiescent for 30 years are written as active. Diseases that are exaggerated from some arbitrary number. The computer says they have this disease, but they haven't studied that there are several parameters involved and they actually don't have it. Have you ever talked about how the patients feel about all this?
I have not studied that, but I recognize that.
Oh, yes. Well, I think overall people are getting worse health care than they used to. I mean, we have more advanced techniques, that is true. But the overall result from the basic care is probably going down.
I think that's what Seema Verma realized, that, it junk in, junk out, and when you're in the hospital with trainees, they cut and paste, and the person that has had a below-the-knee amputation has 2 legs that have no edema on it. It's a real problem.
Yes, and you have so many medical records generated by different places. They're not always compatible. Doctors will say, oh, I can't get the results because this hospital or this lab has an electronic system that doesn't meld with mine. They give you all this, all this poppycock.
Yeah, I think this is what's led to.
I mean, 20
the
years
burnout.
ago, it happened that a doctor made a slight mistake in my medical record. He actually just had to cross out one word. So he went to the hospital, got the original operative report, changed that, and there it is correct. Nowadays, if there's a report, it's already been multiplied in many systems. How do you ever correct this? How do you ever get it coherent?
If you're a gastroenterologist, I think you have a long-lasting career tackling this problem.
Well, fortunately, I'm not a gastroenterologist.
And one other thing I wanted to mention in terms of litigation, and I know we have to go, Eric, so we think all that's seen in the medical record is what we see in the medical record, but behind all that is the metadata, and there's been successful lawsuits, and in particular was an orthopedic surgeon who offered an operation to a patient, and maybe it was a knee or a hip replacement, and was sued because there was a poor outcome of the hip replacement. And what they found in the metadata is that the orthopedic surgeon spent 3 seconds looking at the MRI of the joint, and so it was a successful suit. So be cautious, because not only what you see in the medical record, but the time you spend looking in different aspects of the medical record can be garnered and can be used against us. So be diligent. Thank you, and I'm happy to answer questions at the break, too.